Colleagues on the days, my colleagues from the floor. Well, we've been following quite a few sessions, most very technical, and this has given us an idea of where we have reached, what we are doing in this country so far as cardiology, cardiac techniques are concerned. Yesterday evening, at the opening session, our friend Dr. Ganesh, gave us a good brief of all that has been achieved and what is still being achieved at the cardiac center in Mauritius. But dear friends, all this started one day. We have reached here today, but where did we start? Then at the time together, but most of you may not be knowing what is the journey we traveled to come to this where we are today. So I would wish to present to you as short as possible the history of cardiology and cardiac surgery, of course, because at one time cardiac surgery started. How we started all this? Let us go back memory lane, and the cutoff date would be 1982. What was happening before 1980? A patient with very severe acute chest pain and due to myocardial infarction, reaching the hospital, let's say at 4:30 in the afternoon or 5, would be sent to the casualty to a medical ward and would have to wait for at least the next morning, 9 a.m. or 9:30 a.m. to have the first ECG done. If that patient were of course still alive. How many patients we lost in those nights? That was the situation in Mauritius before 1981-82. And in 1982, this is where we started. It's part of the cardiac unit as a part at Bunwaree at Victoria Hospital. Why part? Because in fact this is the new cardiac unit. The other one, of course, in 1981 was there. It has been improved, and I had to cut the photo to make it resemble to what it was supposed to be in those days. And on the left, where there is that slide which shows the different sections which exist today, that one was not there in those days, and the wall which is there was the wall of a room given inside, where in fact Dr. Sun stayed so many days and nights. That was the place where the RMO, the medical and then he was medical officer, but now he is a specialist, was staying. That was the first place where we started to caused amateurs to stay within the units. I think that today is the only place probably in cardiology or cardiac units or cardiac surgery where you have health officers present in the ward because you know the reasons to need them at any time. So this part was reserved for cardiac cardiology. And in 1982, we had one advisor, Professor Mauritius, in cardiology. He was trained in France, and he was on contract. And two cardiologists in Mauritius, with a team of other cardiologists, unfortunately not, because due to our system, two were taken, but there were others, Dr. Anderson was there, some others were there. We had a group of about 6 to 8 people who could tackle cardiac cases, but officially two cardiologists and one advisor. And before 1982, as I'm showing on this slide, all cardiac problems were taken care of by physicians in medical units. And the main cardiac issues were, as you can see, ischemic heart, of course, infective endocarditis, and rheumatic fever and heart failure. The infrastructure available in those days were, in our small unit we started, which I showed you, with a cardiac ICU, the only one in Victoria Hospital, which was started there, cardiac monitors, defibrillators, time motion echo only, not 2D, you can see that there. Stress test, they are also very archaic to start with. We have that old system of asking people to climb, go around steps, 4 or 5 steps, and then come back, carry on. And then the ECG was going monitored. And of course an X-ray department. And we had a day ward with 10 beds. And those beds were separated by curtains. And ECG room, of course, for us was something extraordinary, but as I told you, ECG was, before being done, only 12 to 16 hours after the admission of the patient, if the patient was alive. Time motion echo, 1983, I must have really helped us quite a lot, in fact, in those days. The first cardiac surgery section, which started afterwards, I'll show you in a few minutes, that cardiac surgery session was done with the help only of time motion echo, and we didn't have 2D echo in those days. Well, these are one or two examples of the echo, time motion. These belong to patients of those days. Well, we had only that at our disposal, and we were working very, very hard to diagnose the cases, which we had to send, in some cases, to the surgeons later on. So far as patient care was concerned, acute myocardial infarction was treated with heparin, aspirin, beta blockers, ACE inhibitors, and nitrates. In fact, one of the major changes we brought was the introduction of intravenous nitrates. We remember Dr. Saran is here, I'm so happy to see him in front of me. And sometimes, you know, he had to stay himself by the patient to monitor the blood pressure once every minute or every 2 minutes, because the blood pressure monitor was not working. So we introduced intravenous nitrates, and how many lives we saved in those days. No thrombolysis, of course, no PCI, no IABP. Valvular heart problems were mainly mitral stenosis with commissuratories, which were being done sometimes, a few, which can be counted on the fingers by general surgeons, closed heart of course, and in most cases we were transferring the cases we could to South Africa or India for surgery. There was a strong prevalence of endocarditis because of the lack of proper use of antibiotics. Now we are going to, after 2 years, we started in 1982. And in 1984, with a team of Professor Hassan Rafa and his Saudi team, we started, in fact, operated on 50 patients, not 30 as the slide shows here. That was the first section. And I'll tell you, Professor Rafa came to the country on his own, and he was visiting Mauritius. He was staying in a hotel. And he was a cardiac surgeon and pioneer cardiac surgeon in his country. He inquired what is the situation for cardiology and cardiac surgery in this country. Finally, he came after 1 or 2 days, because he stayed a week. After 2 days, 3 days, he reached the Ministry of Health, and our colleagues in the Ministry of Health, doctor colleagues, CMO, BMO, etc., curative, brought him in all the main hospitals. Rosebell was not existing in those days. And when he went to Hospital North, he visited the theatre, he said, well, something could be done here. But unfortunately, there was no cardiac clinic. There was only cardiac operating theatre. He could arrange to start cardiac surgery, but unfortunately, there were other things missing on the medical side and on the ICU side. When he came to Civil Hospital, he didn't even enter the theatre. It was so old, you know, with cobwebs, fibers everywhere. Then he went to Victoria, same thing there. They brought him to the theatre, and when he entered the theatre, those days especially, same thing, too old, Victoria Hospital, you know what it means. And unfortunately, he shook his head, he said, unfortunately, you couldn't do that. They brought him for tea in the office of the superintendent. There was no RHT in those days, to the superintendent of Victoria Hospital, our late Dr. Ramdawal. And he said, unfortunately, I won't be able to help you. I am so willing to, I will come with my team, all that is necessary. You don't need to give me anything, but unfortunately, you need to start with medical cardiology. And we were there in about 150 yards away. We were practicing what I've shown you, what I've just shown you. We have started something, at least with intravenous nitrates. Even if I'm not mistaken, we had started temporary bleeding. And he was not aware. And our friends from the ministry brought him to the cardiac theaters, to the operating theaters. And Dr. Amdoa, who was our friend, just called us and wanted us to show him, because he said, you know, we have just started something in this hospital. And it would seem that the people who were in charge of the hospitals and staying in their offices in the ministry were not really aware, or for some other reasons, they didn't want to. Finally, cutting long story short, he came to our unit. Professor Vanigatu was not in Mauritius, he was in France, I remember. He went for some special research. And our friends were Dr. Hamilton, Dr. Ribai, and some other friends with me. I was managing the unit in the absence of Professor Vanigatu. And he visited our ward. And he was flabbergasted. He was amazed. He said, oh, this is being done here. And when we brought him for tea in our office there, he told the PMO, the CMO, if you can put in the Northern Hospital SSRN only what you have done here, I don't ask for anything more. I come and operate in the weeks. Now the CMO couldn't reply because there was some technical aspects behind, and he was looking at me. And then I said, and my friends will understand why, because in those days, it was a check of war. The physicians were not too happy that cardiac unit had started, because we were taking, you know, they were doing all the cases of cardiology before, and unfortunately, as I told you, people were dying because there was no improvement at all. And then I looked at Dr. Moit in his eyes and I told him, Dr. Moit, if you leave our hands free, that is, you don't intervene through other people, I can promise you that we can put this in Northern Hospital within 2 weeks. Everything was portable. We even had a C-arm radioscopy. That also could be carried. Everything was portable, small and you know what is there in an ICU, in a cardiac ICU. Then Dr. Wade said, well, if it is like that, we'll work on it. And to cut a long story short again, 3 months later, that was in mid-1984, the first cardiac surgery, open heart surgery session started in Mauritius by that team. And then in 1986, we decided that we had to start an independent cardiac unit at SSR and hospital, because there the operations had started. So the operations had started, but there was no cardiac unit. The cardiac unit was only temporary at the time the surgical session had to be organized. Then we said we have to have an independent and permanent cardiac unit at SSRN. And I left my friends at the cardiac unit for the work to continue, and government agreed for me to go to SSR Hospital in June 1986. At the same time, 2D echocardiography had been introduced in Mauritius. This is to show that we were doing echocardiography. We had only one main machine, and therefore our patients had to move from hospital to hospital to be able to undergo this test. This is what we were doing. Very quickly you can see, good diagnosis was done, even unique atrium. In 1986, we had 2 surgery sessions organized. One by Professor Alain Seren, because now that the thing had started, other surgeons were contacted, and we didn't know Dr. Ganesan in those days. I think it was an intern somewhere there, around there. But Professor Seren agreed to come and operate in Mauritius, and in June, July 1986, he did come. And Professor Rafa did his second surgery session in August, September 1986. Now, Professor Alain Seren, as you can see, June, July 86, these are sorry for the unfortunately, these papers have been taken from my files. I managed to get them yesterday morning by looking into papers own stock about 20 years ago, more than 20 years, 30 years ago. So this is to show you that we were doing oximetry with the catheters sent in the right pulmonary artery, left pulmonary artery, and patients operated by Dr. Seren, we were talking of statistics in fact. All these were being well organized, and these are some examples of letters that were, in fact, of reports that were done. They were the operating briefs from the theaters during surgery by the surgeon himself. And these are letters that I personally sent because all patients were coming to Hospital North. These are letters, discharge letters, if I can call them, when patients were being discharged after having been seen 1 week after surgery, 2 weeks, 3 weeks after surgery, sometimes 2 months in case of minor or major complications. These were types of letters which I still keep in my files. I happen to get them. Now, Professor Hassan Rafa in August and September 1986 had his second session. Again, these are the reports from surgical procedures that were practiced by Professor Rafa. And at the end of this, you will see there is one which where the surgeon is Dr. Sorifan. Dr. Sorifan, I think he's left the hospital. He's gone into politics also, if I'm mistaken. Ambassador now. But he was then a cardiac surgeon. I must tell you, Dr. Ribai and Dr. Sorifan, there was another Dr. Sorifan together. They went with Dr. Rafa for quite some time to get well involved. And in fact, thanks to that, Dr. Ribai is there and leading this wonderfully well, this unit in the north, while Dr. Rampleton kept our head high with the cardiac unit in Victoria Hospital. So this is where Dr. Rafa allowed the surgeons, Mauritian surgeons, to start operating. And these are examples of inpatient case summaries. The patients were being operated, everything were kept in details, the status of the patient, the examinations that were done, the results that were obtained, and all these in details, which finally allowed me to write a long letter to the doctor who was going to take care of the patient wherever, whatever hospital from where the patient came from. So these, in fact, were patients who were having operated by Professor Hassan Rafa. Now, one thing interesting, I don't think my colleagues know all in that. In 1986, we had a case where, when Dr. Rafa came, a case was presented to him. And that case was a patient of 55-year-old female with a large ASD, pulmonary hypertension, heart failure, and that heart failure was end stage almost, pulmonary vascular resistance borderline, let's say, just within acceptable limits. But surgery was denied to that person because Dr. Rafa told me, we don't know the status of the coronary arteries of this lady, 55-year-old. And therefore, she was denied surgery. She was removed from a list when we were presenting that to Dr. Rafa for surgery. And what we did, in fact, the first coronary artery was done in Victoria Hospital with 2 nurses. One was coming to, and the other one, unfortunately, the lady passed away, Monique, and the help of a radio technician. We managed to find an input in the old system of X-ray department, where the only dynamic X-ray that was being done was the barium meal and barium swab. So we talked to the radio technician, said, well, try to see, and when we looked in the books and so on, he managed to allow us to get video recording. And that lady was going to be denied surgery only because of the status of her coronary arteries. And we were convinced as cardiologists, because we had stress tests done, walk too much. But still, with our experience, we said to Dr. Rafa, we can promise you that this lady has got very good coronary arteries. I remember the sentence he mentioned to me. He said, Dr. Bunwaree, if you were going to pass an clinical examination and you had such a case to present to the jury, would you tell them that without a coronary angiography for this lady, 55-year-old female, that you are not going to have at least a coronary angiogram just to assess the coronary arteries before this surgery? Well, I was then taken in a trap, because definitely the answer would be, no, I wouldn't do that. And then we brought that patient, but it is not working here. No? Slide. We brought that lady in the X-ray department with, of course, plenty of precautions taken, and we introduced. Oh, sorry, thank you. So we introduced, as you can see, a coronary artery in the coronaries. In fact, we had some video filming, but at the end of the day, the nurse told me that this video film, in 2-3 years' time, you'll have to throw it away, you won't be able to see anything. Then you will not be able to put that in the archives, that the first coronary angiography was done in these circumstances in those days. Then we decided to take one or two films, which I am presenting to you. This is the right coronary artery of that patient. And then we moved to the coming up of the full-fledged cardiac center at SSRNH. So we have started cardiac surgery. A few surgery sessions were organized. My friend Dr. Ribai was still abroad with Dr. Surifa. Our friends were working together from Cardiac Victoria Hospital. We were covering the cardiac surgery sessions whenever they were taking place. All of us, or even those cardiologists and RMOs, well-trained in cardiology, moved to Victoria, to SSR Hospital during the phase of the surgery to be able to help us, because we didn't have enough trained staff. And well, for the sake of facility, I found a letter which I wrote myself to the Permanent Secretary of Ministry of Health on the 16th of February 1987. And in that letter I was telling him, as you know, let me quote myself, as you know, I have been posted at the SSRN hospital since the month of June 1986 last. And from then till December the same year, 2 sessions of cardiac surgery have been performed. In fact, there were 3 sessions because one had already been organized in 1984. Later on in the letter, I say, furthermore, this cardiac section has been functioning, I mean the cardiac section at Hospital North. We had one at Victoria, of course. But there, it was at the place where cardiac surgery was taking place. Furthermore, this cardiac section has been functioning only with me as the only doctor, 2 female nursing officers, and 1 secretary. All these papers I showed you were done in those days only with this meager team. The amount and high quality of clinical and scientific work done by this very small team speaks well for itself. I remind you that the letter was sent to the Permanent Secretary of the Ministry of Health. So later in the letter I tell him, however, to complete the project of a good cardiac unit, we have to, number 2, improve the standard of care in a specialized coronary unit, which I intend to start with the actual facilities of the intensive care unit of SSRN Hospital. And 2, I proposed to him that we had to organize a peripheral setup whereby all secondary hospitals, health centers, dispensaries, and community health posts will have to get involved actively to allow this centralized unit at SSRN Hospital to function more efficiently and at the same time give a high standard of care to our patients. We can only do further improvement if a separate an independent cardiac unit is set up immediately. The idea had already been approved at an official meeting held at the Ministry of Health in the office of the Chief Medical Officer around mid-August 1986. We had already decided to go along these lines. And later in the letter I tell him, we have now already structured that cardiac unit at SSRN Hospital, which is already functioning marvelously well and is now only waiting for it to be officially named and launched. And I wish that your immediate attention be given to this matter so that I may continue in the path which I have traced for cardiology at SSRN Hospital, that is, start working on my second phase as expressed to you in paragraph 4 of this letter. And in third phase, I am happy to see Dr. Ganesh somewhere. I talked to him about him in his absence, but I'm congratulating him for the third phase, which in fact involved cardiac surgery in the same place with the cardiac unit there. And what today we have both Dr. Rival and Dr. Ganesh with us and doing marvelously well, presenting to you the high level of cardiology that is being achieved in this country. So, dear friends, that gave the setup came for cardiac center. In presenting to you, well, I wrote these photos from SSR Hospital. In fact, some are on the internet. And Dr. Thomas presented to you, Dr. Yam presented to you the good work we are doing here. And this is the cardiac unit at the Victoria Hospital, where much work has been done, I know, by Dr. Anderton when I was involved, even when another one replaced me, because my letter, which I read to you, was in February 1987, and unfortunately, or fortunately, I don't know, in April 1987, on the day of my birthday, on the 7th of April, I resigned from the hospital sector to join politics, as you know. And then another friend of mine, Dr. Balkubi, was sent to SSRN Hospital to continue the work, and Dr. Anderton, all of them were working together. Then Dr. Yam came a bit later. I think that was the second generation of cardiologists. And after that, with him, there were some other people, I can't mention the name, Dr. Doma, another generation of cardiologists, and the group of Dr. Susan. In fact, it is because of you that I presented this, I made this presentation. This is the cath lab of Victoria Hospital. I understand this cath lab also in Civil Hospital. And dear young colleagues, I can only tell you, where there is a will, there is a way. If you want to achieve, Dr. Thomas just mentioned, we can. And that is what you have been seeing in this presentation, where we started from the people who were dying because of lack of ECG, the basic tool of cardiology, which was not available in 1981, and where we have reached today. I wish to congratulate all of you. I thank Pascal for having given me this opportunity. I thank the chair for having marvelously chaired this function. And I thank all cardiologists, those who were with me in those days, those who come later, and the young generation. I think our country has got, and Dr. Ganesh, of course, with his team, I think our country has a lot to do. Again, in fact, we learned yesterday that we are going in the region as well, and this is well appreciated. Thank you very much for your attention.
Okay, well, thank you very much. I think that was quite interesting and very stimulating. And like you said, if you don't know your history, you will have no future. So that was marvelous. Thank you